Bismillah ar-Rahman ar-Rahim. It's my pleasure to present the Cerebrovascular Disorders lectures. My name is Ashraf Metwaly, Professor of Neurology, Mansoura University, Faculty of Medicine. We'll start by the objectives of the whole lectures of cerebrovascular disorders. Yes, first we have to decide or define our objectives from these lectures: to know the blood supply of the brain, to define cerebral stroke, transient ischemic attacks. The second lecture is to how to approach to a patient with stroke. The third lecture will be about the principal lines of stroke management. As you know from the anatomy, the cerebral arterial circulation divided into two types or two parts: the carotid system and the vertebrovascular system. We sometimes call it the anterior circulation and posterior circulation. The carotid system, from the aortic arch, there is a common carotid artery, then internal carotid artery divided into middle cerebral artery and anterior cerebral artery. The vertebrovascular system, also from the aortic arch, the two subclavian arteries, two vertebral arteries unite to form the basilar artery, and from the basilar artery there are two posterior cerebral arteries. This figure shows the cerebral circulation. As we see here, the vertebrobasilar arteries, the two vertebral arteries, the basilar artery, and the posterior cerebral arteries. Here is anterior circulation. This is a part of the internal carotid artery, which is divided into, this is anterior cerebral artery, and this is a middle cerebral artery inside the sylvian fissure. Also, the main arteries are subdivided into basilar or central branches and superficial or cortical branches. This is a circle of Willis, as we know from the anatomy also. And this is the internal carotid artery, the upper part of the internal carotid artery, and this is the middle cerebral artery, and the anterior cerebral artery on both sides. And this is basilar artery, and comes from it the two posterior cerebral arteries. And these are the two anterior cerebral arteries united by the anterior communicating arteries. And one artery only, but both posterior cerebral arteries complete the circle of Wells. So the stroke is the commonest cerebrovascular disorder, and we call it brain attack like heart attack, but the term cerebrovascular accident is not suitable for definition of stroke, because it's not an accident. Stroke represents the third most common cause of death. Sometimes we, in some countries, make it the second cause of death. The first cause, as you know, the cardiac, then the malignancy, then the stroke. The incidence rate is high, about 15 to 20 per 10,000 person per year. So how can we define stroke? Stroke is a rapidly developing clinical symptoms. You have to stress on rapidly developing symptoms and or signs of focal loss of brain function. Focal loss of brain function, part of the brain or focal or specific area of the brain affected by an artery occluded or something like that, or bleeding in this artery, lasting more than 24 hours. Also, I have to stress on the 24 hours, because you can differentiate between TIA or transient ischemic attack and stroke by the time, or leading to death. Sometimes you cannot reach the patient before death and you cannot diagnose him, but if you did a CT scan, if you do a CT scan after that, you can find like a huge hemorrhage or massive infarction or something like that, with no apparent cause other than that of vascular origin, because we are studying now the vascular or cerebrovascular disorders. So stroke should happen from a vascular problem. Okay, if the patient comes in the ER with weakness of one side of the body, but this after head trauma or trauma to the head during a road traffic accident or something like that, came with the subdural hematoma, whatever the cause, this is not a stroke. This is a post-traumatic brain injury, subdural hematoma, whatever the. Also, if the patient comes in with the brain abscess, this is not a stroke. Even if he has the same symptoms of stroke, but the etiology should be of vascular origin. The main two types of cerebral arterial strokes are ischemic stroke and hemorrhagic stroke. The ischemic stroke results from occlusion, thrombosis, or embolus inside an artery that is being occluded by this embolus, leads to death of some brain tissues or cells that have some function. This function will be either lost completely or affected for a time. And this ischemic type of stroke represents about 80 or from 70 to 85% of all cases of stroke. The hemorrhagic stroke, which is the second type of stroke, represents about 15% of cases. Hemorrhage, rupture of an aneurysm, rupture of the artery, or rupture of arteriovenous malformation, whatever the cause of rupture, and bleeding happens. This ooze of blood will compress on the brain cells and will affect the function of the brain. So as we mentioned now, the ischemic cerebral stroke represents about from 70 to 80% of all strokes. What is the pathogenesis of cerebral infarction? It always happens from sudden thrombotic or embolic occlusion of a cerebral artery. So what causes occlusion of the cerebral arteries? Maybe arterial disease, the wall itself. This cause is about 70% of cases. Cardioembolic strokes, it's about 20% of cases where the stroke comes from the heart, or cardioembolic stroke. Hematologic disorders. So if we go back to the arterial diseases, what are the arterial diseases, which is the commonest one? Large artery atherothrombosis or atherothromboembolism. This represents about 45% of cases of arterial diseases. 40% extracranial and 5% intracranial. Small artery disease, it's 1/4 of cases. Microatheroma or lipohyaluronosis, this is in the wall of these arteries. Other arteriopathies represents about 5%, like arterial dissection or arthritis. The cardioembolic causes, these happen from the problem in the heart, as the heart is the pump to the brain through the arteries, and anything in any lesion in the heart can go through the aorta to the internal carotid artery to the other arteries of the brain. It's either anterior or posterior circulation can happen from any lesion in the heart. What are the causes in the heart? Like atrial fibrillation, mitral stenosis, endocarditis, myocardial infarction, atrial myxoma, prosthetic valve, mitral valve prolapse, congenital heart diseases, cardiomyopathy, cardiac surgery. So something in the valves, something in the the contractility of the heart, something in the wall of the heart as cardiomyopathy, cardiac surgery, myocardial infarction. All these can cause cardiac embolic stroke. The hematological disorders like polycythemia, leukemia, sickle cell disease, hypercoagulable state, essential thrombocythemia. So now we will go through the what are the risk factors for cerebral infarctions or ischemic cerebral stroke. What are the risk factors for that? It's very important to know what's meant by risk factor. Risk factor for a disease or risk factors for a disease are characteristics of an individual or of a population associated with an increased risk of the disease. So this is something in the individual or the population, specific population, makes them more prone to have a stroke or the disease. Okay. So the risk factors, we can classify simply these risk factors into two main types. Non-modifiable risk factors that you cannot modify. These risk factors like increasing age, you cannot stop the age, male gender, African American race, if the patient is having a previous stroke or there's a family history of strokes. Sometimes the strokes runs in families. Modifiable risk factors, this second type of risk factors, we subdivided them, modifiable by medical treatment and modifiable by lifestyle improvement. So modifiable risk factors by medical treatment like high blood pressure or hypertension, diabetes mellitus, heart disease, transient ischemic attacks, or raised hematocrit. So you can modify these risk factors by medication, by treatment. You control blood pressure, optimum control of blood pressure, rigorous control of diabetes mellitus. If there is a cardiac disease, you have to fix it or treat it. The coronary heart disease by stent, by anticoagulation, by whatever, grafts. If there is atrial fibrillation, you have to give the patient the prophylactic medication. Transient ischemic attack, you have to take care of the patient with transient ischemic attack and give him the medication, or we have to search for the etiology for that to prevent actual stroke from happening. Raised hematocrit, also you have to treat it. Modifiable risk factors by changing lifestyle, like cigarette smoking, hyperlipidemia, and the lipids, the cholesterol and triglycerides. Physical inactivity, you have to encourage exercise and activity. Obesity, it's one of the risk factors. Stress for life. All these risk factors can be modified by changing the lifestyle. Let's go to the clinical features of ischemic stroke. It's a focal loss of neurological function. It's one part of the brain affected. There is weakness on one side of the body, contralateral to this side of the affection. Negative in quality means there is no activity in this place. If the patient is affected by infarction or hemorrhage, there is weakness, paralysis, and loss of speech like aphasia or dysphasia, dysarthria, and rapidly developing, because it's an arterial circulation, rapidly or suddenly occluded, and the developing of symptoms is rapid. and also maximum at the onset. When the patient comes in the ER, you can see him in comatose or severe or marked dense hemiplegia, very severe weakness or complete paralysis. So it is maximum at the onset. Regarding focal neurological disorders, it's in carotid or vertebrobasilar according to the symptoms and signs. If it's carotid, it will be focal symptoms and signs. Hemiplegia, hypothesia means there is, the sensation is affected on that side of hemiplegia. Hemianopia, this is a field effect, and aphasia if the lesion in the left hemisphere. Focal neurological symptoms and signs are due to vertebrovascular affection, vertebrovascular artery affection, unilateral or bilateral, plus disturbance of cranial nerves. As you know, the brainstem, there is cranial nerves there, and we will discuss the crossed hemiplegia after that in the approach to the patient with a stroke in the second lecture. Now we will define the transient ischemic attack. Transient ischemic attacks or transient ischemic attack either in the carotid or vertebrovascular circulation. The definition is acute focal loss of brain function with symptoms lasting less than 24 hours. This is the differentiation between the actual stroke and the transient ischemic attack. So if it proceeds or the symptoms continue for more than 24 hours, now we consider it stroke, not a transient ischemic attack, and which is thought to be due to inadequate cerebral blood flow. So it's the same, more or less, the definition of cerebral stroke, but the time of persistence of symptoms less than 24 hours. This is the point of differentiation between transient ischemic attack and the actual stroke. So the definition is retrospective. What's meant by retrospective? You don't know if the patient will continue as a stroke or will stop before the 24 hours these symptoms. So you can diagnose this patient after passing of 24 hours. But nowadays, all the the literatures and the studies say that it takes not more than 1.5 hours, something like that, to resolve. So it's very important to differentiate between transient ischemic attack and actual cerebral stroke. So what's the pathogenesis of the transient ischemic attack? It's sudden temporary thrombotic or embolic occlusion of a cerebral artery, or low flow distal to an already occluded or highly stenosed cerebral artery. Also, if you want to know if it's this transient ischemic attack due to carotid system or due to anterior circulation, or posterior circulation, or what's meant by the other name is posterior circulation. Symptoms of carotid TIA, it's ipsilateral transient loss of vision and contralateral motor or sensory dysfunction. So what's confusing here? Why is the visual on one side and the weakness and sensory symptoms on the other side? How can you explain that? If the carotid artery on the right side is affected, so the left side of the body will be affected. This is the contralateral side because the right carotid supplies the right hemisphere. So the contralateral side of the body will be affected. So what will happen to the eye? Because this artery on the right side gives ophthalmic artery. So ophthalmic artery will be affected on the right side, and the left side will be weakness due to hemispheric affection on the right hemisphere. I think you got the point. Aphasia if the lesion in the left side, convulsions if the lesion is cortical. Symptoms of vertebrovascular TIA. Alternating hemiparesis or hemisensory symptoms. It's something in the brainstem, something like that. Dysarthria, dysphagia, diplopia, vertigo, imbalance, vomiting, loss of consciousness, or vital signs alterations, because all these dysfunctions happen from the brainstem affection, drop attacks, homonymous hemianopia. This is also one of the field effects you will study in other lectures. The investigations of TIA, this is for TIA only, because we will give a lecture about the investigations and how to approach to the patient with stroke in the ER. The investigations of TIA, duplex carotid ultrasound, because just mentioned that there is a carotid problem or vertebral problem may cause this TIA. Echocardiography, because you have to exclude cardioembolic strokes if the patient is having any problem in the heart, especially atrial fibrillation or something like that. You can expect the etiology or the cause of this TIA. Transcranial Doppler, also you can see if there's microemboli signals through the Valsalva maneuver and the injection of agitated saline in the artery, in the brachial vein, and makes the patient makes the Valsalva maneuver. You can, through this transducer of the transcranial Doppler, you can get some microemboli signals. Cerebral angiography for more delineation of the lesions in the cerebral arteries, CT or MRI of the brain. So the investigations of TIA is very important. You have to do it, and in some centers they admit the patient for full investigations to avoid the actual stroke to happen, because TIA makes the patient more prone to have a stroke more than the patient who doesn't have a prior TIA. The treatment of TIA, also according to the etiology, and anticoagulant if the patient is having a high cardiac risk factor, antiplatelet, endarterectomy if there is a problem, major problem, severe stenosis of carotid artery or vertebral artery, and also control the risk factors. Generally, the prognosis of stroke is not good, but it depends on the site of the infarction, where this infarction is in the brainstem, which is, if it is large in the brainstem, the prognosis is not good. The size of infarction, the large infarction is, actually it will make disastrous stroke, and sometimes herniation and compression of the other vital signs, and herniation and midline shift with a lot of problems. Sometimes we do craniectomy for these patients to relieve the patients the tension or the edema inside this infarction, and to avoid this compression and herniation. The patient's age also, the older the age, the more guarded prognosis. If there is prior comorbidities to the stroke, if the patient is having uncontrolled diabetes or hypertension, severe obesity and morbid obesity, and other factors in the heart, if he has coronary artery disease, these are the factors that makes the prognosis guarded. Even with the best treatment for these patients, 1/3 of them die in the first year of stroke, and 1/3 remain disabled 1 year after stroke onset, and 30% suffers recurrent stroke within the next 5 years of stroke onset. The cause of death in these patients in the first week after stroke may be due to direct effects of the brain damage or brain herniation, which is just mentioned before, due to severe brain edema and compression. There is death after 1 week of stroke that can happen due to some complications like bronchopneumonia, venous thrombosis, or recurrent vascular event. This is just a general look about the stroke and the definitions of the stroke and TIAs, and the pathogenesis of stroke, the clinical picture of stroke, and how to differentiate between TIA and cerebral stroke. And the next lecture, inshallah, we'll see how to approach to the patient with stroke. Thank you.